my name is Sue Robbins, and I'm presenting this talk from my home in Vancouver. I'd like to first acknowledge that I live, work, and play on the unceded lands of the Musqueam, Tsleil-Waututh, and Squamish nations of the Coast Salish peoples. I grew up in Edmonton, and I went to the University of Alberta, so presenting a talk to an Alberta-based conference feels like coming home to me. Today, I'm going to plant seeds. I know as researchers, you're used to going deep into one topic. Today, I'm going to give a bird's eye view of 3 different topics. The first one is storytelling. I'm going to talk about both patient and professional stories. The second thing I'm going to talk about is relationships, and that's the N of 2 that's in my talk's title. And I want to speak on moving beyond researcher to patient, to authentic human-to-human relationships. And the third thing I want to talk about is system change versus individual change. I'll start with my own story. This is a picture from my daughter Ella's wedding last year. She got married in August 2019, and we're very grateful that her wedding was in 2019 as opposed to 2020. This picture was taken in Naramata in the Okanagan, and I'll introduce everybody. At the far left is my son Aaron, who is now 17 years old, and he has Down syndrome. And Aaron really is the person that introduced me to the world of pediatric healthcare as a mother and a caregiver. Next to him is my husband Mike. Next to him is the groom, Ella's now husband Isak. Then there's the bride, who is my daughter Ella, and she happens to be a pediatric RN at the Stollery Children's Hospital. My son Isaac is a musician, and he lives in the States. And then there's me. Today, I have my patient hat on. So I'm presenting as someone who is a recent breast cancer patient. I was diagnosed and treated for breast cancer 3 years ago in 2017. I'm also going to talk to you as a writer. I'm the author of a book called Bird's Eye View, which is a story of my life lived in healthcare. I really love this picture because it's the last time that our family was all together, of course, because of the pandemic. And I know there's many folks out there in the audience who can relate to that, especially if you have loved ones far away. I want to make it clear today that I'm here only to speak about my own stories, and that I don't represent patients as a whole. I also want to acknowledge my privilege as a middle-aged, white, middle-class woman. So just keeping that in mind as I go through that I'm only speaking about myself. The theme of this virtual conference is Beyond Research, Transforming Health Systems. I want us to remember that the system is made up of people. It is individuals who made decisions to build the system that we have today. Therefore, it'll be individuals that will make the change to the system that we're looking for. This has to do with how we treat each other, person to person, what I call the N of 2. I worked for many years trying to change the system. For the past 15 years, I've sat on committees, I've started councils, I even was the chair of a national organization of family councils in Canada. I sat on national pediatric disability research committees. I've been the volunteer subject of research many, many times as both a caregiver and a breast cancer patient. I even did work, paid work, as the family engagement advisor at both the Stollery Children's Hospital and BC Children's Hospital. And last January, in 2019, I had an identity crisis. I came to a screeching halt wondering what was the point of all this work, sitting on committees and boardrooms on phone calls. Did I make any kind of difference at all? And perhaps you've thought of that too, had that same epiphany with your own work. What difference does it make? To what end are we doing this all? My identity crisis and patient engagement came back to this, my why. And this is a great graphic from Simon Sinek's TED Talk. and I've got all the references for everything I talk about in this talk at the end of this presentation. He says that we often focus on what we do or how we do it, not the why. If you had asked me my why over the years, I would have said, I want to make a difference in healthcare. But now I'm not so sure I can change the whole system. I think I can be the change that I want to see. That means if I want to be treated kindly as a patient, I myself have to treat people kindly. And if I want folks to celebrate my son who has a disability, then I have to first celebrate him. I think that change comes from within, and it will travel from one person to another to another. It's the best sort of contagion, unlike our current COVID contagion. My identity crisis has brought me back to my why. Why do I do what I do? When I'm sharing stories with health professionals, this has always been my main message. The life of my son is worthy and deserves to be celebrated. In fact, all my family advocacy work always comes back to this. This is my why. When I got cancer, I added to my why. I was looking for, desperately, more humanity in healthcare as a patient, and in fact, more humanity for all. My main message now is to be kinder than you think is absolutely necessary. More compassion in healthcare is now on my list of my whys. Did any of my time on committees and councils and projects lead to positive change in practice that helped improve things for patients and families? I have no idea because that was never proven to me. But anecdotally, and that's actually all I've got, I do know that sharing our stories can help make a difference. I once shared this slide in a presentation to a group of NICU staff. A few weeks later, a social worker stopped me in the hall and she said, I was thinking about your slide and I decided to change the way I approach new families in the NICU. She said there was a family with a sick baby and I started by saying congratulations to them instead of I'm sorry. And the social worker told me it changed the whole relationship she had with the family. It helped reframe it. These stories can really stick with people in a way that data doesn't. I want to pause here and ask you about your own why. Why did you get into research in healthcare? And if you're a patient partner, why are you partnering with researchers in healthcare? I think digging deeper into your own why helps find the essence of your own story. And I'll also add a bit about communications. I really believe in the knowledge translation of your own research. Consider sharing your own story about why your work is important to you, whether it's a personal one or professional one. I'll give a couple of examples of that in a moment. There's my son Aaron. He's looking pretty badass wearing his mask. I wanted to talk about COVID. I think it's strange to see talks where people don't talk about the fact that we're in the middle of a pandemic right now. So what COVID has really done is given all of us a health angle to our stories, even if we're not actively a patient. And I have to say, sickness now is not just something that's someone else's problem. And one of the hardest parts about me having cancer was having to look at my own mortality to become face-to-face with that. And now that's something that we all have to do, whether we're patients or researchers or clinicians. And it is actually quite chilling. So when you consider your own story in healthcare, I also want you to think about how COVID has changed your story in the past 6 months. I think that part is important too. So I've got a couple great examples about the use of storytelling in knowledge translation. And the first one is Brene Brown. Of course, she is very well known, and in fact, she is the queen of storytelling in research. I once saw her at a social worker conference, and it was very interesting to watch her. She was talking about her research about vulnerability, and all the social workers in the audience assumed that she was talking about vulnerability with their clients, because of course, in order to get referred to a social worker, typically you're in a vulnerable situation. But in fact, she wasn't. She was talking about vulnerability on an individual level with them. And I have to say, the whole room was like really uncomfortable about that notion. And it was interesting to see them shifting in their chairs and realizing she wanted them to think about their own stories, not the stories of their clients. So what Brene Brown does really well is she weaves in her own story, her own sense of humor, her own humbleness, as well as her personal experiences into sharing her research. And I think for knowledge translation, understanding and sharing your own story with audiences will help you communicate your research. Another example, and this one is Canadian, is from Dr. Christine Chambers. She's a pediatric pain researcher. She does a really great job of weaving her own story in when she communicates about her research. So she was a pain researcher for many years before she had children. And then one of her children ended up being hospitalized, and she realized that all that research she had done in children's hospitals had not been adopted into practice. So what she did was very clever. She partnered with moms groups and also harnessed the power of social media to get the word out widely about best practice in pain research. I think her why, and I'm making an assumption here, was that she wanted actual change in practice, and she had to do that by communicating better. So my pitch to you is to consider how you can use stories in your work. And my N of 2 is best illustrated by this picture. It's of nurse practitioner Kathy Reed with my son Aaron about 8 years ago when he was quite a bit younger. And what it really shows is the connection the two of them have, and the fact that they appear to be quite delighted with each other, whatever conversation they happen to be having. And when I talk about N of 2, I wonder how healthcare, including health research, is actually about relationship between a patient and a researcher and a patient a clinician, a patient. Whether you're working with patients in research, as subjects of research, or partners in research. And authentic relationships with each other is really between human beings, not between professional titles or roles. So that means you have to let patients have a little peek into your own hearts, your own story, your own why. I have 3 short stories from my work at the Stollery Children's Hospital. I call these little stories anecdotes, and it helps illustrate the power of authentic relationships. The first one is about the tights on the slide. We were having our very first Family Centered Care Council meeting a number of years ago. On that council were administrators and clinicians and families who had children who had patient experience at the hospital. Everybody was in this big boardroom. The whole thing was a bit intimidating. There was a mom, and she ended up sitting beside the senior operating officer of the hospital. I talked to the mom afterwards, and she said she was quite nervous and didn't know what to say. The senior operating officer noticed the mom was wearing these funky patterned tights, and she leaned over to her and said, "Oh, I love your tights," she said. And that immediately broke the ice. And the two of them were able to talk to each other as human being to human being, as opposed to senior operating officer to mom. And they bonded over their own sense of fashion. And that might seem like a little tiny thing, but it actually was a big thing and helped set the tone for that mom for the rest of the meeting. The second thing I want to talk about is coffee. And in my work at the Stollery, I did a lot of outreach with families. And what I would often do was meet them in coffee shops in their own neighborhoods to get to know one another. And it used to kind of be a running joke that Sue was going for coffee again. But in fact, doing that and breaking bread together in a coffee setting was something that was a really powerful thing to build relationships, to get to know each other as human beings. And a lot of it had to do with meeting on neutral ground. The third story is about another setting, and it is about our Christmas party that we held for the council. We ended up having it at our home. It's a picture of the tray that we offered when people came in. And one of the reasons we had it at our home, I think, is so we could offer alcohol, because we couldn't do that at the hospital. But also, it was a very family-friendly event. So we invited everybody who was on council, including their families. So the physicians showed up with their little kids, the administrators did, and of course the families did too. And there was something about getting to know each other in a family context that was very powerful and really helped set a very strong foundation for that council going forward. So really, I want you to think about the settings where you engage patients and how you're meeting them maybe on their own turf instead of asking them to come in to your office or your boardroom. I know we're doing everything on Zoom now, but thinking about how we can really level that playing ground going forward. I want to tell another story about a relationship that blossomed with a researcher and a health educator during a very dark time, and that's when I was being treated for cancer. I ended up in a manager's office at the cancer hospital. I had a number of ideas about how to improve patient experience, particularly in the waiting room areas, but I had for some reason been labeled as a complainer. So I was in as a complaint to that office. The meeting didn't necessarily go that well, but afterwards, the clinical educator, her name's Amanda Boulderston, contacted me and asked if we could get together as follow-up. We ended up meeting at a restaurant close to the hospital for lunch. In fact, we had ramen. That's a picture of the actual ramen. So I like to take pictures of my food that we ate. And what happened there was, it was actually pretty magic. Amanda and I got to know each other as people. She's a mom, I'm a mom. We both have kids with disabilities. We're both big foodies. So we bonded in that way, as opposed to she was the staff and I was the patient complainer. And it was actually a very, very powerful thing. Later, we ended up writing an article for the Journal of Medical Imaging about our relationship. And I've got a link to that at the end of these slides. And it proves to me, if we are willing to allow ourselves to be seen as real people and not just as titles or roles, I really believe this is where the magic happens. So back to relationships, the N of 2. And a mom taught me this once, and I think it's such a powerful thing. And it's kind of a marketing thing, but it can apply to relationships in research very easily. So relationships are built on see you, know you, like you, trust you. And so how do we even get to know each other? And that's through sharing our stories, those little bits about ourselves. My big epiphany after my identity crisis was, how do we change the system? And I think that we change it one person at a time through sharing our own stories. Stories help us feel something. Change will only happen if we feel something for one another. Me understanding you as a researcher, you understanding me as a patient. It needs to be reciprocal. Often clinicians and researchers hide behind a wall of professionalism and never allow us to see them as people. I know my own oncologist never let me peek into her heart, and really that damaged our relationship because I struggled with trusting her. We understand each other through listening to our stories, and I really believe in storytelling to make change. But stories also have to be solicited in a respectful way. So here's one last thought for your work. Are you using patient stories, or are you using patients for their stories? How do you follow up with patients to let them know their stories made a difference? Closing that circle, that feedback loop, helps let us know that we've been engaged in an authentic way beyond a checkbox. Follow-up is really crucial to feeling like we haven't been used. This is the opening quote from my book that's called Bird's Eye View, and it's a quote from Audre Lorde, who wrote this amazing book called The Cancer Journals. That was a really pivotal book for me. I read it when I was in cancer treatment. I hope her sentiment helps give patients who are watching this the strength to share their own stories. I know it did for me. I want to read an excerpt from my book from a chapter called The Patient's Storyteller. The way out of the chaotic storm of illness is to tell stories. The best sort of people are those who create space for stories. They can sit with an uncomfortable story without minimizing it, interrupting, looking for the bright side, correcting the storyteller, or running away. Encouraging patients to tell their own stories in their own way paves the road towards healing. We are afraid to speak up, but as Audre says, it is better to speak. Think about how you're honoring patient stories and how do you honor your own story. I'd like to end on a thank you for the work that you do. This is meant to be read as, we are all here on earth to help others. What on earth the others are here for, I don't know. I know in health research, you have a great curiosity about people's stories. I'd encourage you to consider being vulnerable enough to pause, to look at your own story and understand it, and to share it with others. I promise you that will help you create more authentic relationships going forward. I wanted to share all the references in my talk with you so that if you do want to dig deeper into any of these topics, these are some great places to start. And here's a bit about me and where you can find my book. Enjoy the rest of this virtual conference. I know this is different this year, but as I found out in my life, different is not necessarily bad. Sometimes it can be even better. Thank you.